takes forever for that music to play, I swear. Welcome back, everybody. This is the PreHospital Paradigm Podcast. I'm Scott Wildenheim, and as usual, we got a Caleb Ferroni here. And in the empty seat, as per kind of recently, is going to be jetting in just a second, is our infamous Dr. John Hill. And then we also have our returning for our live show, our Doctor of Data and Documentation. I've been holding on to that one for a long time to introduce you as that.
That's one way. Okay, all right.
John Cameron. So
the triple D is on triple P.
Triple D, triple P. There we go. So, hey, welcome back. And so your episode, we did. They wouldn't know the timing of when we recorded that, but that was done late last year. So it's been almost a year.
Yeah, there was snow on the ground.
Yeah, when we shot that, and if any of you are paying attention, there's been obviously incremental improvements in our audio and our video quality over the time, and we were kind of reluctant. It's like, well, we have this content. It's really good content. Do we put it out and take a step backwards? But it actually I think it played pretty well. So, and then kind of unanimously, we agreed that that we enjoyed even re-listening to that and preparing for today. I thought that was a darn good episode for one of our first out of the box.
I mean, there's nothing more. I don't enjoy anything more than documentation. I mean, it is. What more? You could talk trauma and shock, but no. Documentation is where it's at.
What more is there to life, right?
I can think of a few things. But what more in life is more important in some aspects to us than
what is going to keep us out of trouble and do the most long term for our patient, of course, is documentation. Thanks for joining us, John.
Yeah, happy to be here. Happy to be seen.
Doctor/producer. Got it. Okay.
Yep. Yeah. Doctor producer. You got Doctor Producer and the Doctor of Data here. So. Since this last episode, obviously, a lot of time has elapsed, and I really was using that as a setup for a lot of things in the health EMS,
right.
And the charting world, of course, have fluxed in that year because, and we addressed that in the original series, of course. This is not a stagnant thing. We know what we're doing today is not what we were doing yesterday, and certainly not what we'll be doing tomorrow. And I know you've got a list of some stuff, but let's talk about some of the big changes from then till now, and then let's talk about some stuff that maybe we can look forward to in the next year or so.
All right. So starting off with, as I think everyone knows on this podcast, is that under UH, most of our agencies are using one EPCR platform, which is Sancio Health EMS. So for that platform, we've had at least 3 or 4 releases since that podcast. Some of the biggest changes is that for data integrity, EPCRs that have been opened and have not been edited in 18 months will be deleted from the system. So now you're not going to have EPCR sitting there for 2-3 years that don't go unfinished. So that is one thing we've been really trying to reach out to every agency and make sure that they have a good audit process in place to make sure that these EPCRs are getting closed out. So that's probably one of the biggest, most important things is that actually our audit going back to 2018 revealed over 500 EPCRs that had been opened, had patient names in them, and were never closed.
There was no
with actual data in them.
With no disposition or
yes, they were not completed charts and did end up getting flagged for deletion. So
were these mostly sign off by chance?
Or? A little bit of everything.
Wow.
I mean, if they had a patient name, there was a real chart in my case. Was the way I looked at it.
Mind, sure.
So we did archive most of those. We're still working on that process, but that's something everybody should know is that you should be reviewing that. One of the next releases coming out, I don't know if it's going to make it before the end of the year, but first quarter anyway, will be an actual email sent to the email that is registered within Health EMS, notifying you after 3 days if you haven't closed out that chart. So you're going to get some type of back and forth notice that tells you that you have an open record. So that's going to be very, very valuable in making sure we don't have those EPCRs floating out there.
I feel like I was pretty loud in one of the town hall meetings about that specific thing. Is that was the Nemesis in my old shop, right? That was my job every morning is I went in and looked at open charts from the previous days, but it was always I ran it for the day before, because turns out if you run it for day of, you see all the active charts as well. Yeah. And I may or may not have moved around some active charts unintentionally, right? So I was always parsing a day behind to make sure that there was some level of completion. That same concept of it's going to go away after 18 months, that applies to deleted stuff as well, right? That's not just stuff that was started.
Correct.
Right. So
even if it's been flagged for deletion, it will be cleared out of the system completely.
So all right. So 18 months, regardless of where it's at, if it's not been submitted and finalized, then and then we have the ramifications of that patient encounter was lost. God forbid that's one that winds up going to court, or there was somebody seeking additional information on, and also that's reimbursement that your agency is not going to get.
Right, there's $140,000 roughly, sitting
so
around.
You put a value to that, yeah.
Right, yeah. Spread out across 60 agencies, but still, it's money on the table, and most importantly, it's a record that our physicians in the hospital didn't get to review. So a lot of people ask me, like, well, no one's really looking for it. I guarantee you start asking your medical directors next time that they're out, they're looking for these charts. We have a system in place to get the PCR into the medical record within about 20 minutes after you close it out. Yeah. That holds true, and the physicians do look for it.
The other piece of that is, even let's say you just bring a bogus TOLAC, right, or something into the ED. All right, they might not be looking for that one, but if we're talking anything of any substantial nature, the individual service lines, so the trauma service, the neuro neuro service, they are those services are specifically looking for those. I mean, and they need those for their reaccreditation. Our trauma coordinators are doing an audit and doing a recertification. They were sitting in here. They were absolutely going through historic EMS records and looking, making sure that was matched up to, for their audit process. So it's huge for everybody. It's not just emergency medicine.
And even post-life, too. I mean, if you're looking at organ donation and such, they need those documented charts as well. They're looking for hemodilutions and how much was given and what was given. And so there's huge trickle down there.
Yeah, how salvageable the organs are. And yeah, absolutely.
And not to beat the dead horse, too, but look at the get with the guidelines, criteria, and stuff that we use to try to pull out your city, individual cities, accreditation or whatever you want to call it, the awards for the AHA. That's all coming from all that data that has to make it through. You have to get outcome data back on that. So all that stuff is important. And you may have a patient that you didn't call sepsis alert on, but does turn out to be a sepsis patient. Well, what's really going to be really important? They're going to start to look to see if you did find fluids and how much. So I mean, all those things that may not have seemed like an acute case at the time, but there are ramifications, and I think people are looking at those charts in some cases. I
think your sepsis is a great example, because they can count. Let's say they only wound up giving X amount of fluid in the ER.
Right.
The total amount that they got, can include EMS, right? So, we can help them meet their treatment criteria, his treatment criteria in the emergency room.
Well, it's what the patient needs, right?
Welcome to the conversation. Wow, he was more engaged than I expected.
But even more to think about.
But yeah, of course, it is what the patient needs, right?
It is what the patient needs, and that's from the surviving sepsis criteria and what we're supposed to do. And they need 30 per kilo of fluids, and the sepsis people at the hospital try to include everything, whether that's the liter you guys gave in the field, plus even the volume of fluid that's in the antibiotics, if that's going to count towards the fluid resuscitation. And they do look at that, right?
I hadn't thought about that part.
Yeah. So they'll include, let's say if it's 50 or 100 mLs of fluid, they'll include that in the fluid resuscitation if we're trying to get to that 30 per kilo, if that's what they need. And they'll even use, if you guys document not even tachycardia, for SIRS criteria, it's above 90 a heart rate above 90. So if you document 95 and 95, and then they're never above 90 for me because you guys appropriately started fluid resuscitation, you brought their heart rate down,
Right.
they're still going to meet that SIRS criteria. And if we identify an infection, they're sepsis right there, right? So those criteria that we're calling those sepsis alerts in the field, that they're meeting these two SIRS criteria and they have an identifiable source of infection, they are by definition sepsis, and they have a higher mortality because of that. And probably newsflash to everybody else, we don't want people to die. We want to take good care of people.
That's news, right?
And
And if we end up going down the road of EMS starting first-line antibiotics, ceftriaxone or something, it'd be important to even document whether or not the site was cleaned with chloroprep or alcohol if you're drawing labs, and whether or not we killed something before you had a chance to look at it. So, I mean, documentation is going to roll into all of this.
yeah, because as soon as we give intravenous antibiotics, essentially the bacterium is gone.
Right.
Any bacteria that are susceptible to that antibiotic are knocked out.
Okay. So hopefully that takes care of. That's the big part. So that was one of the biggest changes. Sorry, I have an agenda I want to get through.
Clearly.
Parkland
Before your agenda, though, and I do want to get through your agenda because you got some great stuff on here. We're live on both platforms.
Again, yes, now.
Fantastic. That was really the question. And just a reminder that we really want audience participation from you all. I was waiting to make sure that we were green-lit before that little bit. So if you can jump in, feel free to ask us a question, or if you have some commentary on this. We can see this on the big monitor. It's right behind the cameras here. So we would love to get some feedback and some input from you. We don't just want to sit here and talk for an hour. We would certainly like to get some little bit of audience participation.
Positive and negative too, because if you have problems with Sanzio, this is the guy to talk to.
Yeah,
I'll take it. We can handle it.
that's right. So anyway, what else? Data. It's the meeting we were in. Was it Friday or 2 Fridays ago or Thursday, whatever day it was? Data. What do we do with this, right? Why do we need to click so many boxes in our charts?
All right. So
and why does the audience wanna hate us so much, even though it is very necessary?
So let's start with this even came up within the past couple of weeks. There was a certain hospital who our squads were upset about very long wall times, right? Both non-UH facility and a UH facility where wall times were coming into question.
Yep.
So both hospitals pretty much said, prove it. All right, no problem. So we can take your patient, your at the hospital time, compare and run that against your patient transfer of care time, and now we're every week or every month, I can't remember when we're running the query, we're pulling all those for our entire system, 350 some odd thousand reports a year, to show who's having wall time issues and where. And if we start running that in a shorter cadence, we can have live data of knowing where the surge is, so forth and so on. So so that's kind of where we're getting to, right? Yeah, definitely slow spots. So that's one of the things that we are looking at. That's probably one of the newest. Outside of that, I think we've talked about this ad nauseum, is the ketamine, where we're doing. I just did a bunch of cases this morning and sent them out for all of our ketamine, all of our RSIs. We pull all of those data and we do full case reviews on all of those. The other recent issue was glucagon.
Right.
Ray, I'm glad he's not here because we probably get him all riled up talking about medication shortage, but I believe there either is a glucagon shortage on the horizon, or I'm not sure if it's affecting us yet, but there's a possibility of it. So we started doing glucagon reviews. So having everyone on one platform documenting the same way gives us the power to be able to go out and pull that data and find out where we're using them. When we found out some agencies were using way more glucagon than everyone else. And when we got really dug in the data, we found it was high utilizers.
It was high It was individual patients. Yeah.
Yep.
Yeah. That was a really outstanding part of getting that original data back. And we're like, why were these 4 departments by orders of magnitude, right? It's not like they had used 2 or 3 extra compared to everybody else on average, right?
Right.
I mean, they were using just dozens and dozens and dozens of doses. And yeah, you know, I was part of that, right? We teased that out. It was the high utilized.
It was a very small patient population.
They were like 5 patients that accounted for, you know, 96% of the glucagon that had been used in the system. It was nuts.
Right. And what that helps us get our community involved, you know, or get our medical directors out in the community and going and working with those patients if they haven't been identified. So, you know, we're working on those processes too to make sure that those patients are getting the care that they need, because we're able to tease that out of the PCR. I assume most of those clinicians had already notified their medical director of a patient they're running on every 3 days, but you know, still we're watching it too.
Right.
One of the next, go ahead.
Yeah, that's not transparent to, you know, a lot of, you know, if you're checking those boxes and you really don't understand, like, oh, I'm doing the thing, right? I'm doing the thing. And we'll come back to the importance of the event log versus because that always needs to be discussed.
Yeah.
Versus the narrative. But you know, let's use that glucagon thing. Even if it's new news to everybody out there that's watching that there's a threatened glucagon, you know, shortage. We're already working through that to form a plan. Yeah. Like, we've got 3 or 4 different options already kind of, you know, teased out, and you know where we can go with that as a global organization, and even some pilot programs in various, you know, who has it, who doesn't have it, you know, how we allocate that. All that's working on the back end, even though, you know, it's you're just checking a box on your PCR. That's still very important. Power of the data. The data.
Well, I've been in meetings where we're like, when we did our switch over from one CPAP to a different CPAP. Well, how many did we do this? Oh, give me a minute. Last year we did 33,000.
Sure. Right.
Oh, instant data to make us make a decision if we're in a meeting of to what the next step's going to be, even on the fly, not necessarily something we're scheduled to do queries on, but things that we can actually have actionable information live when we're trying to make a decision.
And like I want everybody out there to act surprised when that's kind of John. When I tell you it's kind of John's job. When everybody else is talking, he's sitting there pushing the buttons.
And you saw protocol updates too. That the same thing happened with ondansetron. We thought we might run into a problem where it was going to be a shortage, so we
baked in the regular.
Yep. And so
the metoclopramide.
Did it happen? Not yet. And knock on wood, it doesn't. But it was there just in case.
So. Yeah, and even the other thing that we started looking at is we started looking at quarterly zero-use medication. So are we spending a ton of money putting drugs in the box that are never getting utilized?
Correct.
And now we can start reviewing, maybe we can pull that off the protocol or pull it out of the box. So those are all things that I'm sure everyone would like to see a few less medications sometimes. But if it's not getting used, then maybe we start to look at whether we can pull it out or not. So that's another one of the queries we use. And then the last one, the most recent, was patients that probably should have gone to a trauma center were not being documented as going to a trauma center. They didn't document why. So we're able to push out there, everyone, if you've gone on a trauma in the past few months, there's a new criteria box that says, hey, here's why you should be going to a trauma center. If you're not going, please tell us why. And it's just a matter of people forgetting to document the why sometimes. So now we have an extra flag in there. So those are some of the UH-specific changes that have happened and some of the data that we are pulling on a recurrent basis for our system.
And don't forget, on a micro level too, the department coordinators have the ability to put red flags in place for their charts for specific things. We added one in ours for a while just on, did you obtain a billing signature? And it wouldn't let you pass unless you did it. For mileage, for example, if we go to a certain hospital, it pings and says, wait a minute, are you sure about these miles before you submit? So on a micro level, there is a lot of freedom there to add that too. And I think that yourself and other people there be more than happy to help people through that and setting that up. And it's not that hard.
I don't know if I asked this on the recorded or not, but what cross section of departments do you think take that extra leeway that is baked in to customize health EMS to their specific need and stuff that is important to them?
Not a lot.
I would say less than 15%.
Out of the charts that I QC, I don't ever see custom fields being utilized.
Yeah.
So
And then there's some people that it takes 10 minutes for a chart to load because there's so many of them. So.
I'm not that bad, but we have a couple.
They just get the spinner when they load
Did you
it.
use sailing? Yes. Why? Yes. Yeah, why? Yes.
because.
Healthy Mess Manager loads so slow for one
Scott.
particular agency.
One particular
I swear,
agent.
last time he logged in, Cleveland dimmed for.
But no, and so it's important to mention that myself and Mike and David are available to
Right.
all of our UH agencies. If there's a particular field you want to tease out, you're not getting it out of your departments, or you're seeing a deficiency. I was reached. One of the billing companies called me this week, said, "Hey, I've got 5 departments that their mileage isn't coming up right, and they're billing for 1 mile."
They're losing out. Yeah.
They're losing out on that. So what can we do to institute a change? And there are software changes we can use to calculate mileage. So I've been reaching out to those departments to try to move that. So there's so many things that we can do. And a lot of our departments have been on Health EMS for 4 or 5 years.
At this
And
point.
it's probably a good time to, let's just sit down.
Refresh.
Schedule 30 minutes with somebody, with myself, Mike, or David. Let's just run through. Let's turn off a few fields if we can turn off. I'm a big fan of, you'll hear me say this 100 times, if I can save you 1 click, I will save you 1 click. That click adds up 450,000 times over a year, whatever it is. That all matters. So we will try to turn off everything that we can to try to save those clicks. We don't want to waste time.
And make the clicks meaningful when you do have to use click.
Right.
Yeah.
Yeah, absolutely. So yeah, let's review everybody. Give us a call. We'll sit down and put some time with everybody and make sure that we're utilizing our time wisely.
And I'll tell you, the 3 people you mentioned, all 3 of you are fantastic about getting back to departments that call for information and help, and it's like having you almost in the back pocket. You can pull it. All the time I'm bugging one of you guys about something, and hey, I'm QCing this chart. What do I do about this? And hey, this is how you do it.
Yeah, that's what we're here for. I'm glad to hear it. I'm glad to.
No, it works out.
Good.
There is an annoyance that I keep hearing about, though, about resetting the password every so often, and if you don't, you stop losing that integration factor. Do you see any fix or workaround for that?
No. So that's the ER one. So between Health EMS and emergency reporting, no. ER has a password that expires every 90 days.
I think it's 90.
So that user account needs to be updated every 90 days. If no one logs into it, then it goes dormant. And
there is a really easy walk-around PowerPoint solution that you guys have, and I think the link to it is on our PreHospital Paradigm.
That is I'm glad you said that. That is a very important point. So on, I was going to do the shameless plug later in the episode.
Just gonna get it out
now
of
is as good a time as any, and that's of course at PreHospitalParadigm.com. John and Mike and Dave's. They have an entire website that is hot linked in our site, right? So if you click on documentation, it actually takes you. If you click on documentation in the PreHospitalParadigm.com. It actually takes you out of, and it goes right to your product. And there is more than just Health EMS stuff there. There's stuff for the monitors. There's all kinds of additional training
Locally, if I'm
videos.
asked questions on how to do certain things, after I've stepped somebody through it, I say, hey, did you check this out? And when they do, it's like, oh, it's all right here.
It's all right
and I don't
here,
know,
man.
nobody really seems to know about it.
It's still kind of new, but Mike is our PowerPoint guru. He has put together so many resources and put them on that
And they're
website.
fantastic.
So if you're on our event med staff, there's a whole section for event med, and then if you're a manager, there's a manager section for system admins. There's a little bit of everything for everyone there. So if you just want to brush up your skills and maybe save yourself time, right? That's really what it comes down to. Is we want to have these tools out there so that you're not getting frustrated. That's my number one thing is what I do for my department. Well, the reason I got into this data thing was because I was frustrated with the software. It was taking me too much time to write a report. And I'm like, I don't want to do this anymore. I'm going to try to find a way to streamline it. So that's what I try to do for my own fire department is let's find out the easiest way to get these things done, to get the data that we need, but make it easy. So again, I don't want you guys getting frustrated. Go to the website. There's plenty of resources there, or just reach out to us.
Sure. 2 things, and if people are probably asking questions. I think you guys all know this fine gentleman here.
That's
Chris.
like he's been on the podcast.
Yeah. How about that? Complaining about his passwords recently.
He's made his return. Right? Welcome back, Chris. Good to see you again.
But I do want to bring up, and one of the questions that I get a lot from my agencies that are using another product for NIFRS reporting or fire reporting. Why don't you talk a little bit more about that?
All right, so let's start off with this because I saw the password question. Let me grab password first.
We
Sansio-
only have a half an hour.
Okay, Sansio starts. I'm gonna talk fast. Sansio's 90 days, unless your department has they have training in place to be HIPAA compliant. You can back that up to 6 months, but you have to go through annual HIPAA compliance training, right? So that is up to every chief themselves or administrator to make sure it's set. So yes, there's a 6-month option in Sansio, but you have to check a box that says you're compliant with that HIPAA compliant.
Yeah.
All right, so that's the first thing. NIFRS fields is what your question was, and
NIFRS fields and what fire reporting and NIFRS information can people pull out of Health EMS to satisfy their reporting needs, to have one platform for all their reporting?
Okay, so Health EMS does have NFIRS reporting built in. It is provided by university hospitals. We have about 70 departments currently utilizing that software. Sansio is spending a lot of resources, and I know this because we work with them. David and I and Mike are working literally on it almost every single day to customize it and make it more robust. So up to the last couple of years, it was just for NFIRS reporting. Now there's hydrants, there's hose, there's building inspections, there's fire safety inspections, there's vehicle inspections. So all of those components are being built out and made to be a true full fire records management platform is where we hope they're going to get to. And the big wrench in all of this is, if anyone's not heard about NERIS, so the fire administration federally has said they're going to do away with NFIRS or NIFRS, whichever, depending on what part of the country you're from, and they're going to a platform the moniker is NERIS, I think is what they're using, and that's supposed to be up and running at the end of 2024. Oh. So all fire softwares are going to be completely restructured, Health EMS included. So they're continuing to build what they currently have out for the current needs, but their new platform built to NERIS standards. Keep in mind, federal government hasn't even given out the data dictionary yet.
Hasn't even completely defined it.
But they said by the end of the year, the data dictionary will be available to vendors, and so the new version of Health EMS's Fire is going to be in the Mobile Touch platform. So you won't have to log into Health EMS Manager to do your NFIRS instance anymore. You're going to actually do it in Mobile Touch like you do your EPCR. So that's where we're going. Fingers crossed, everything, timelines keep together, and NERIS, gets launched when it's supposed to and gives the vendors the time to get this stuff done.
I mean, federal government's involved. Nothing can go wrong. I mean, this is gonna be on time, on budget.
Will there be a scheduling platform in there as well?
Scheduling, not so much. So one of the next releases, I can't remember if it's before the end of the year or Q1, is going to be a daily log. A lot of customers have asked for. So that daily log feature, that may build to scheduling, but I don't think so. I just don't think they're there yet. That's going to be maybe 2025 or something if they go that route. But they're not Sansio to this point has not really put any stock into being a payroll company, right? Fire records management is where they're trying to put their resources.
Sure.
So I like this question about the event log. I can tell you on a small scale.
So why don't we read the question?
Yeah, sorry, go ahead.
You read it?
No, he wants you
I
to do
find
it.
myself documenting information in the
might not be
narrative
able to
that is already reflected in the event log just because that's how I've always written in my narrative. Am I duplicating the effort or no reason, or is this good practice? I think on a small scale, and then going back to you on a huge scale, I think that if it's not in the event log, it's harder for me to pull quick data. And if it is in the narrative and it's not on the event log, you might have done it, but again, I'm not going to be able to QC that real quick. So
I think there's one answer here that we can unanimously agree on is
do both.
No, that wasn't it, because I think he and I are absolutely kind of polar opposite in this regard. But I think we can all agree that if you did a thing, it's got to be in the event. It has to be in the event log because we can't tease it out of the narrative.
Right.
Now, this is where opinions will start to diverge, right? Scott is I rewrite everything, right? I want, for me, if I go to court, my story written my way from the beginning, and again, we talked about many in the previous episodes. We talked about many different ways to write this, and this is just my practice. I'm not saying it's right, but I write everything chronologically. distilled, extremely distilled, right? But so. No, Will, I'm with you. That's that's my personal practice, is to do something like that.
If
right?
you want to waste your time,
Yep.
you go right
Yep.
ahead.
But we
I
also-
don't care. As long as.
See, like I said, we diverge a little bit.
I'm a lot with Scott, though. I agree that if I do it, first of all, it needs to be in the event log. It really does, because if it isn't, it didn't happen. You can put it in your narrative, and then who's going to pick through that? But I want something that I can paint, that I can recollect 2 years from now, and be like it was there again.
Yeah.
So
But yeah, like I said, I'll extremely distilled, right? So I'll put start at IV. Do I put where, location, size, fluid, flush?
When I have the stroke
absolutely not. It's
coordinator
in my
call me,
event
though,
log,
and the
right?
first thing they ask is, did the squad do a van assessment, and they do a sugar. I'm not looking, the first place I go is the event log, but they've already looked there. So I usually go right to the narrative, and that's where I'll find it. It's like, yeah, they did, but you didn't check the narrative. And it's like, oh. So
If you want to waste your time and redo it, just make sure you don't contradict yourself.
Contradict,
and that we
right,
see
you're
that
right.
way too many times, is that when I do read a
That's
narrative and I
always been
find...
it's always been your point.
Right. So now, not only have you wasted time, but now you've opened yourself
Set the
up
circumstances
for,
up. Right. Yeah.
incorrect data. So which one was it?
Yeah. You have to be comfortable with whichever method, right?
Right. Yeah. And so, the narrative structure does not
Yeah.
matter. Chronological seems to be becoming more and more common. No more samples or anything like that. But as long as you're getting the data in there, telling the story, it doesn't matter what format it's in.
Yeah.
But it does seem like as time goes on, I see more and more people writing in a chronological state.
And that's how I do my documentation. I always do chronological. It should be in both. It should be in the event log. I think a good summary of the care you provide should be in your narrative, and that's what I do in mine. In my version of my narrative, which we call MDM or ED course, I write what I saw when I first saw the patient, just like medics do when they first evaluate their scene. They describe what the scene is, what they are. Mine's always in the same spot because I'm in the hospital,
Sure.
the ER. But what the patient looked like, basically sick or not sick. And then what my initial assessment, are they tachycardic, are they hypotensive, like how sick are they,
Right.
if I'm saying that they're sick. And then what I did, if I'm going in there, we're doing a code, we're doing a code, I gave a summary of how many epis we gave, or how many bicarbs we gave, or calcium we gave, or if we gave lidocaine, or if we gave amiodarone. I'm giving you a general overview, but there's always some detail, and what we call it a code sheet, the event log for Health
Right.
EMS, that shows the detail of what happened, but I'm going to go over what we did. I don't have to go line by line, because all that detail's everywhere else. But I
Right.
think that it's worthwhile to say, I did some things generally. What were these things? For summary, I gave 5 epis versus 3 epis. I can quickly read through the narrative, understand what happened, and then what happened next.
I think it's interesting. A lot of times, a physician even will say, "Okay, insert my normal narrative," and it's right. So
Start now.
I do a lot of the same thing. I copy and paste. I have in the notes on the iPad, I have my narrative, and I copy it and I paste it into the narrative field, and then I just have question marks where I need to fill it in. That way, I know it's the same every time, and I'm doing the same steps every time, and then I just fill in where I put question marks.
Yeah, see, that's I struggle with that. Right, that's too much of a framework for me. But again, it's all rehearsed.
So
I
I
think we
think
talked about this. I also do voice to text. Right.
Sure.
You got to watch that though.
You absolutely have to watch that, right? Because that'll get you in trouble real fast.
Yeah, if you're not proofreading.
The one thing before your thought is, regardless of whether you put it in the event log with the event, so I did an IV justification for why you did it. And that IV is probably a bad example, but needle thoracostomy, or taking an airway, or right.
I would argue those are large events you should summarize and give a reason as to why.
So-
No breath sounds on the left side, need to be compressed.
Right.
And that's
I
what I'm
agree.
going to say.
I
It doesn't
agree.
need to be any more than
Right, it
that.
can be distilled,
Yep.
right?
And all of that is in the event, and I see the comment here, the BGL is in the vitals section in the event log. It absolutely is. But I can't tell you how many times people don't put it there, and they put it in their narrative. So it's very easy to just put it in the event log, and it's easily found as well.
Searchable.
Yeah, it's very searchable.
And possibly billable, because if it's not in the event log, you can't. A billing company's not going to read every narrative.
Correct.
They're going to go based upon what items you checked and what you did to then justify your level of care, and then are individual things billable out.
And the particular BGLs and vital signs and in the event log, that's actually agency specific. Not all agencies have BGL built as a treatment, and that is agency specific. So again, if the powers that be at West Green's department want to turn that off, we could probably get that fixed. But it's all agent. That's an agency thing. And
But on the other side of the coin, like we were talking before, if they're having an issue obtaining BGLs, you could also make that a power field.
Yep.
So if your department specific is having no BGLs, make it a power field.
I would say it's more the reason why I put it into event log, because something significant happened, even if you document unsuccessful attempt and as to why that happened.
yeah, I mean, there's lots of different ways to document, and even with the narrative, there are pre-built narratives where you can customize a auto-generated narrative in Health EMS.
Yep.
We do not have any agencies currently have that activated because I think it's too much of a crutch. I think there are some departments that could probably, with really good oversight, utilize it, but I am not a fan of it unless there's really good QA oversight to make sure that that the picture is being painted and the patient conditions is being documented correctly.
Well, we talked about this on the pre-recorded show about giving patient reports, right? How people of a certain age before cell phones, you guys are calling in radio reports.
Radio
to the
report,
hospitals,
yeah.
And you got to hear really good or
Really bad. Yeah.
radio reports. Like, man, I don't want to be like that guy. I think that, to your point, that if you have pre-written documentation like that, it is too big of a crutch. You should be very good at doing your documentation to the exact same time. Even if I can look at any document. I don't have to see who signed it, if my name is even on it. I can look at it and go, that's mine.
mine.
That's not
Yeah.
mine. Because it's written the exact same
It
way.
plays the same way, right?
So I think this is the best
This is the best
request.
idea we've had so far, right?
So
I'm going to lose, but I think it is still awesome for live TV.
All right,
Thanks,
who's
Chris.
arm wrestling?
So we all have to arm wrestle simultaneously.
But that interesting part of that is that you have four people at a table with different opinions,
Correct.
right? And then it's just the way it's
Well,
going to be.
that's the important message to get out there is, and this is probably not a one perfect way to do it. It's just make sure that you understand the deficiencies in whatever process you choose,
Yep.
right?
Absolutely.
Or the benefit of the deficiencies.
I think the point too is there's not one right answer, right, on how to do the documentation. There's things you should do. There's multiple ways to implement it, and it's going to more come down to not necessarily what the four of us want at this table. It's going to be what your medical director wants. So interface with your medical director, talk with them, ask them what they want, ask them for feedback. Say, hey, would you mind reviewing some of mine? And I've done that for people. I've specifically read all the reports on a certain day and given them feedback on it. And then whatever your department wants, whatever your white shirts want at your...
I have read your
Place as well.
report. I have no idea why you were at this patient. Why you had this patient.
I like that you brought that up because something did come up the other day, and Dr. Spanner was the one to bring it up, that if your medical director or whoever's doing your QCing sends you back something,
Ooh, good point.
give us something back that says I received that, or else I have no idea to know that closed loop communication happened.
A simple, got it, doc.
Got it, done.
Yep,
Yeah.
okay, but yes.
So,
Right.
just the K.
Just K is fine.
Anything
New York
that shows that Dr. Spano or any of our medical directors can, when they log back on, they're going to see, all right, fine, they read it.
They
I know they read
acknowledge
it.
that they got it because there's nothing that tells me that it's been read or any of that. So just a simple, understood. Okay, like you said, something just to know that I can close loop communication and doc, they understood it, they got it, we're good.
Yep, 100%.
And you can always request medical direction review. I think somebody's alluded to that a minute ago.
Absolutely.
You can click a box that
there's a
says I
button in there.
request
Yep.
medical direction control. There's only a few of us QCing, so be patient, but we'll get to it.
Yeah, we've probably fallen behind on that, I'm not going to lie. Just we don't have the resources to stay up on it. And so some of the docs are taking on that themselves. Some of, their own agencies, each agency specific is watching for that. We launched that with the intent that myself and Mike and David would do those reviews. And it's just unfortunately that we have not caught up on it. But that does not mean that as a system, you might have administrators in your own department that are doing that for you to help out, and the medical directors.
That and you can always
We
call
as-
your EMS coordinators too and ask, hey, I need a follow-up on this.
Well, and I'll even say that for my squads, and I think that I'll go for everyone else's too, if you check that box, I'll get notified of it. Like most of us have email notifications set up. what I think is lacking in the system, and I've requested a change, is that give me a text box so I know what about this run you want me to review. Hey, I want follow-up on what happened to the patient. Hey, I wasn't sure what to do at this time. Hey, I think we did a great job. I really want you to review the case. And there's always options there. I don't know what specific feedback that they want from that interaction of what they want from that review. Whether that's, hey, man, this person almost died. We gave push dose epi. We did all the things, and they're doing great. And they walked out of the hospital. And last time this happened to them, they were there for 2 weeks.
2 weeks, right?
Yeah. So I want to give that squad an attaboy. You guys did a great job. You did exactly what you should have done, as opposed to, hey, I wasn't sure what happened with this patient, or we had a problem, which I guess also we should maybe talk about how people can report issues, whether it's personnel in your squad or public or hospital that you're having issues with. I don't do this. Is it the last page?
Last page of the protocol. Yep. It's the back of the protocol.
There's a form you can fill out that's anonymous. Just
It can be.
It can be.
It can be. You certainly can use that to self-report, right? Whether that's errors or concerns or safety issues. That is not a platform to. Well, we got to sign this call, and there was there was another truck that should have done it, or that's internal.
It's not a tattletale button.
No. That's internal strife that needs to be figured out in your own agency. This is for. Patient-centric reporting of issues and concerns, right? How can we make care better?
And I would encourage people, if you do have a medication error, to report. I personally like that's the way to do it, and that way, you should tell your command staff. You should report it to your EMS coordinator there. You should tell the hospital when you get there if you notice it, or if it's after, call the ER and let them know any errors that happened, and then report it. We want to know. About those errors. We understand that people are human. We all make errors. I make errors. Just be upfront with it, report them, and we can deal with them. And then if we notice, which very recently we did, we noticed that an error was happening more often than we would anticipate, and we make a change to what's in the drug box, or how something's labeled, or put it in a baggie, put it in a different colored baggie, so that way to separate them out to stop those errors from happening in the future.
Yeah, that was the complete purpose of that is, what systems can we put in place to keep these errors from happening?
Ondansetron, olanzapine?
Say it ain't so, man.
So I just thought of something I wanted to bring up while you were here. Recently, I've noticed that some squads are taking 8, 10, 15 minutes to get out the door, and I found this trend, and I think I know the problem that we adjusted. A lot of times, and I'm not going to single anybody out, but Geauga dispatch, for example, when they page us out is the time that they receive the page, and they might sit on that time until they page the department, because maybe it's not a medical issue right away. Maybe it was a non-injury motor vehicle accident, so that's the encounter time. The page is going to be 10 minutes later. That in Health EMS is pulled over in Sanzio, and it's telling me that I've been stagnant now for 10 minutes. So we really have to keep an eye on that and know that if you want to cut down on those times, which you can significantly, make sure that you're putting the time your department was paged as your encounter time.
Yeah, unfortunately, it's probably a dispatch-specific issue.
But if anybody else is having that issue, trend your times and make sure that that's not the case.
Right, and there's a ton of reporting out of Health EMS that they can run on the report section to show, there's dashboard items that you can build to show, turnout time. Yep. So it's what we still effectively call the turnout time, right? So those can be put on your dashboard. You can monitor it every day and watch trending. So that'd be what I would do for that if I was noticing that from my department.
Yeah. So just an FYI, if you're seeing that, maybe just double check those times. And I'm not sure if it's just Sanzio and Geauga or other.
It's going to be unique to just Geauga, for sure. I did get text question instead of on the platform.
My phone's been vibrating. I wonder how many I've ignored.
We have a department asking if the medical directors are QAing our medical first responder departments and our non-transporting departments.
Ooh, yes. Yes, we are.
Okay.
So anyone that's under med control, whether or not they're using Health EMS or not, although the majority of them are, they're all getting QA'd as well. Similar system. If it's going to be, we can't possibly QA all 300,000 runs, but a portion of those do get QA'd. And if you have a concern, either reach out to your med director, because if it's local, it's probably going to be the same med director, or if not, use the report function on the back, or reach out to your local EMS. Like, ask a question. We'll be happy to. If you have a concern with patient care, we want to know about it, so that way we can make things better. That's all we can do. We want to do that.
To your previous point about the review requested, I solved that in my former house by putting a power field on there. So when they pecked yes, it forced a field of what do you want? Right? What do you want? Tell me a story.
Another box.
Another box. But guess what? When they clicked it, we knew what they were looking for.
Do they actually have to then repeat that question in their narrative also?
Repeat it in the narrative? No, it just comes. There's a filter set then for the other.
Well, you like to duplicate things. I was just curious.
I voiced the text of the same question in there. And
so that brings up more fields. Brings up probably one of the other things I wanted to hit on today, if we have time, which is Nemesis 3.5. So I think Nemesis.
Let's hit on it.
Yeah, Nemesis
Let's do it,
3.4 came out. I want to say 10 plus years ago, roughly.
Why don't we take a step back and why don't you tell them what the hell Nemesis is?
Oh, the Nemesis? My Nemesis?
Your Nemesis.
So Nemesis has once, somebody told me it was one of the largest public databases in the world. I can't validate that, but it's a very large data set. It is very well structured, and it is when you say you're sending your EPCRs down to the state, that's what we're doing. We're saying Nemesis is the national model for it, and then our state in Ohio is MSERS, is what they call it. So it goes to MSERS, and MSERS then puts it up to the national database. Right. So the versions have changed over the past few years, and or the past 10 or 15 years. Right now, we are getting ready to roll out to the state of Ohio has said in 2024 they will start accepting Nemesis 3.5 data. So what does that mean for us? More clicks.
More clicks.
So from the software standpoint, Sancio is already Nemesis 3.5 compliant, as well as, I believe, emergency networking we have in our system. ESO is Nemesis 3.5. ISO, I did not see them on the list when I checked today. I believe they're trying to get their certificate. So that it's coming. It's going to be a change in the way we program or the way we document. One of the biggest changes is going to be the outcome or your disposition. Instead of having that static 12 or 15 items, it's going to be kind of a flow. So you're going to say, yes, I got on scene. Okay, when you got on scene, did you encounter a patient? Yes or no? If not, then it kind of cuts you off there.
Right.
If you did encounter a patient, then it takes, okay, then did you treat them? Right. And it kind of works you through that process. So it could, we'll see how many more clicks it's going to add. The nice thing is we can change a lot in Sancio. We're able to change the wording in all those dispositions too. So that's going to be nice. And with the Nemesis 3.5 upgrade in Health EMS, we also have scenario-based situations. So we're going to be able to build if-then statements in Health EMS. So that is going to be a huge... Right, that can have a huge benefit to our data collection. So lots of exciting things there. I can go into more detail, but we'll stop there.
The geek in me is so happy.
Nemesis 3.5 is coming sometime in 2024. Most likely they're going to start accepting data. They haven't said when they're going to stop accepting 3.4.
Okay.
Wow.
Yay.
Scott's glowing.
I'm Battle Scott Gray as usual. So, all right. What else do we haven't hit? That's
well, I can run through some of the things that have changed since last December
let's hit those. Yeah,
we definitely have one more question to get to too. That's from our website, not necessarily from our live question or streams as well. So
okay, we'll leave 37 seconds for that.
Yeah.
Okay. So since last December, whenever whenever we recorded the last show, some of the other updates again to Health EMS has been visible entry in your event log. So before you would only see, I think, pulse rate and blood pressure.
Oh yeah.
So you would have to go to the print preview to see your respiratory rate and your BGL and so forth. So now we've added SpO2, the BGL, and injuries in the visible event log on the tablet. So you don't have to go to preview for that, even though I will encourage everyone before they export the call to always look at the report in print preview, because that's the way he's going to read it. There is a new field, if it hasn't, it should be released next week, that is administered by patient. So for our EMTs, I believe their scope of practice allows the patient to self-administer certain things. Mm-hmm. So there's going to be a new box for that, so we can track how often they're self-administering.
Very nice.
The training tracking. So Health EMS released a training tracking module into Health EMS. So those departments that want to really dig into that, we built it so that you can record, each of the state of Ohio, you have to have so many hours of trauma. It's going to go into that trauma bucket and tell you how many more hours you need. So it's a nice, easy way to keep track of all of your training and certifications. Next week, you can set up provider impressions to then require provider pre-arrival alert. So when we rolled out pre-arrival alert a year and a half, 2 years ago, we made it mandatory for everyone. You have to always say whether you called stroke alert, STEMI alert, so forth and so on. So as of next week, you're going to be able to say, if your provider impression is stroke, did you call a stroke alert?
Force it.
So that's going to hopefully reduce some clicks. Again, that's always my goal, if possible. We talked about Nemesis 3.5 and scenarios. Social security numbers. The longer your agency is on one particular EPCR platform, the more patients you collect, right? As long as you collect enough information, the PCR platform creates a patient's master record that then you can recall so that you can run subsequent trips on them and see what their medical history and so forth is.
And medications.
And their medications.
So if you enter it the first time, especially for
Correctly.
patients.
Enter it correctly the first time.
Right, and that's a big thing for like assist. So I try to tell everyone, take that opportunity when you're doing an assist where it's a low acuity call, get that patient record built. That way when you go next time when it's higher acuity, you've got all that stuff.
Back on those patients?
Believe it or not, we actually end up transporting a lot of the same patients.
Wow.
Yes. Yeah.
That's bizarre. I would never have guessed.
Yeah. So what I do tell my agencies to do, it's quick and convenient to take that picture we talked about in the recorded show to, line up the medications, take that picture, attach it, you're golden. But then when you're going back and you're finishing up your report, if it's the first time you've gone on a patient and they've fallen or for sure that you're going to be seeing them next shift, 2 hours, or definitely next month, go back in, build up their medications, build up their past medical history. So that way next time you go and you go, yep, next, done.
Ride back to the station.
Yeah.
Just reconcile that against what you
all
snap
of the
picture.
meds, even the folic acid,
Not
even
No.
Okay.
Not all meds are created equally, and hopefully my squads have heard me say this a bunch of times, but your antiarrhythmics, your antiplatelet medications, your blood thinner medications, your immune modulators, those are the medications we really care about.
Okay.
Folic acid, not so much.
All right. Well, it's important to know. Again, we're going to reduce button clicks, but still want you to get the important stuff in there, right?
Stuff, yeah. Yep.
So
everyone in Northeastern Ohio is on vitamin D, right? And or should be, and if not, you'll look like Scott. So.
This is treated. You should see me. You should see me without.
So where I was going with that is that it becomes more and more difficult for the software to create a new patient file or find your old patient on that information. So there are a lot of Scott Smiths in the world with a date of birth that maybe somebody entered incorrectly, maybe not, maybe they got the right year. So it's going to be really important that we try to collect Social Security numbers as an additional identifier or a driver's license number. One of the really neat features that's going to be coming out very soon also is driver's license scanning of using the camera on iPads. Since we have a lot of iPads in circulation or UH, you'll be able to scan that barcode and input their information into the chart from that.
It is a beautiful thing.
That's going to give you that information to help make that patient a little more unique. Make sure you get that patient matching. And I think that's it for a
map. You added map.
Oh, that's right, map. I forgot to bring it up.
Only thing that I needed you to do, you got done. So that's why you're my hero.
All right, map is in there.
Map done.
Correct. No math needed.
No
map is in the chart.
if you put in a manual pressure, it automatically calculates.
Using a life bag is
likewise.
doing it anyways. It's
And
just not your stupid
if
stuff.
the machine is, but it wasn't in the report.
No, it wasn't in the report.
Now it pulls across, and I am just so happy. My life it's complete.
Glad to hear that.
Oh, the things that make him happy.
It's my inner geek, right?
Well, since we got about 5 minutes left and more than 37 seconds, I think.
No, let's only allocate 37 seconds to this.
Oh no.
So as a reminder that
as
we
a-
have our website.
as
You
a-
can go on there. You can submit questions on there as well. So for the people that are either watching this after it's recorded or live, and you don't want your name to show up, you can submit questions anonymously, and this is what one of these is.
My reticence is this could be another hour, right?
Fair.
Right? But
I don't think so.
we can give a quick summary, but
So when under DNR CC protocol, one of the do not perform actions is cardiac monitor. However, patients required to be on the monitor if we're giving medications. So what should we do in this case? Or what do you guys do in this case?
I'm not putting the patient on a monitor to prevent. I'm not changing anything with the monitor other than making sure that what I'm about to do isn't going to change anything. I guess it's not diagnostic. I'm not looking for an underlying rhythm that I'm about to treat. I'm giving a medication, so I want to make sure that first I do no harm, and by looking at what they're at, I guess is.
I don't even.
go ahead.
I don't think that. I mean, So one of the reasons why we put patients on monitors, depending on the medication we're giving, we're going to look at what effects that medication has on the patient. You're not doing any harm to a DNR CC patient who's in hospice who is struggling for shortness of breath, and you're treating that with an opioid. That's not doing any harm. You're doing good treatment in that case. It could be of value to put a patient on a monitor to see what the effects of that medication are. I would even argue that sometimes it's not even required to put them on a monitor.
And just to trend rate and rhythm, right? It's a non-invasive technique, right? As long as you're I think what you were kind of getting to is as long as you're not making major intervention that breaks the DNRCC,
if I
like
put
I'm using
somebody on
this
a
as
monitor
justification
and
to defibrillate cardiovert,
Right.
take an airway.
If I put somebody on monitor, I see a third-degree heart block. I'm not going to do anything about that.
Right.
That's not why I'm here.
Right.
But if I put them on the monitor and I see a prolonged QT syndrome, before I give ondansetron, I know it's kind of
Sure.
But I might
That
withhold
would be
that.
reasonable to say, I'm not going to make this situation worse by giving a medication that's going to have a known side effect to prolong this QTC even more, and then I'm actually causing harm because now we might have the possibility of sending a patient into a dysrhythmia. What would you do in that case then? Would you...
I mean, you would outweigh the odds. There's just withhold it. If I'm just using it as an antiemetic, why, let's just get to the ER and have the physician or talk. If you have a coherent patient, they're always willing to, I do want a chance that I want to take this or not, and let me explain it to you. And then if not, the POA should be relatively available.
Yep.
But when in doubt, call med control.
So, I was going to say,
Right.
Because I can also give you other medications you
Yes.
could try that might have the same effect on the patient, which is going to have not necessarily
safer profile.
Yeah, exactly.
Yeah, absolutely. The other angle that I've had to work historically is, let's say somebody is end of life, right, and they are going to expire in my care, right. Now I've got another documentation piece here of, I need to justify that the patient's dead when I'm talking to you.
Absolutely.
That the patient is asystolic, right?
Yep.
So again, it's non-invasive. It's a non-invasive thing. I'm doing that for documentation purposes.
Right.
Right.
You're not taking action based upon it.
Patient began to brady down at this point. QRS widening. Now no visible P waves.
Yep.
That's stretching out. Now it's
This could be such an
agonal
open
rhythm and
can of worms. But
That's
another
why I
problem
was
you might
reluctant
run
to get into it.
is if you're on a hospice patient who is.
Well, that's what we're talking about, right? We're talking about the hospice patients.
But
that are on
who
DNRCC.
is your med control at that point? It's still you. Don't get me wrong. But what I'm saying is you might show up and be given orders that the patient needs copious amounts of pain medication. But I'm like, that's way above my control.
Sure.
But the doc is there saying, or the nurse practitioner, and saying this is end of life. This is a different protocol. I'm still going to call you and say, hey doc, this is what I'm dealing with. But in that case, I mean, who is in charge of that?
So we talked about this during sports medicine too. You're always going to be, if you're operating under, in part of UH,
And EMS, yeah.
and EMS,
You're my go-to guy.
I'm your medical director, you're operating under my license, it's always going to be me. It's not going to be that person there. If it's that person there, they're going to take responsibility. It's under their,
And it's their license.
It's their license. I would not do their orders directed.
And there's a very scripted part of the protocol for that,
yes.
for that situation, right? I had something very intelligent to say, and it's gone. Absolutely gone.
I did too.
We were gonna. I was going to start. Do you want to add in palliative care? Add. There's all these things, but at the end of the day, right? Getting the docs to talk. Our goals should all be aligned, and if that is what that takes, is that call to medical control and be like,
And all of us are going
here
to be
is
happy
this
to talk to whoever's there.
situation, situationally dependent. So,
Absolutely.
And we're lucky that we have the scapegoat of calling you. And I hate saying that, but that's what it is.
But that's
I am
what they're
working for your license, and if I'm afraid of anything or questioning anything, I call you.
But I want you to call, right?
Right.
I want you to call and we'll have that discussion. Hey, I'm between A and B. This is going on. I don't know what this is. Hey, they told me this. I've never heard of that drug. I've never heard of that condition.
Yep.
Help me out here.
Yeah.
Or cognitive offloading. Hey, I'm in it deep. I need help. What should I do next? Because my brain's fried. But that's why we have online med control, and to call online med controls not a bad thing. We want you to do that. I think I said this during the pre-recorded session. There is not a shift that goes by that I don't lean over to my partner I'm working with and say, hey, look at this EKG.
What do you think of this? Yeah.
Can I just run this patient by you? Am I okay doing this? What are your thoughts? And that's me just consulting my colleague to make sure that...
what am I missing?
What am I... Yeah.
Yep.
Or am I missing anything?
Right,
I don't think I'm missing anything.
Right.
This is what I have. No, you're fine. I think you're...
It just doesn't feel right. Yeah.
I say it all the time, especially to my students, but once you pass registry, there's no cheating here. Reach out, phone a friend, call for help. What you were going to say?
You can cheat all you want. You can cheat all you want after registry. But
what I mean by no cheating is there's cheat all you want.
Right, no,
there's
I
no
understand.
not
Yeah.
cheating, I guess is what I should say.
Yeah, and you're going to have your phone there. You're going to have your resources there. You're going to have your favorite app there.
the entire subplot of this entire series is medical control is your friend. Call medical control. Right.
I think
This entire series. We
phone.
touch on that. I swear in every
single time,
episode.
yeah.
So,
Pick up the
right.
phone.
But we harp on that so much because we're trying to hopefully break some stigma here, which is. If it's not written down, we don't do it. And you're allowed to be smarter than. I've said this before. We said it all said these parts before, right? You're allowed to be smarter than protocol. If we get one more person to understand that, right? You're allowed to be smarter than protocol. You're allowed to have a bad day. And you're definitely allowed to ask for the opinion of your medical authority real time if it's going to benefit the patient.
Absolutely.
And you're allowed to be wrong.
Yeah.
Because it happens to every single one of us.
So back to this question, I think putting on the monitor is okay.
It is. Absolutely.
Even to the point where you guys, how many times have we been called for, oh my God, my mom, whoever my loved one is dying, they're DNRCC, I've got a signed piece of paper, and hospice is there, but I'm still calling 911 because I'm scared, right? And you guys show up and they're agony breathing and they're requesting some IV pain medications or IM pain medications. Put them on the monitor, give your medications, sit there a few minutes and see what happens. If you want to call us. We'll be happy to walk you through the process.
I've done exactly that, and personally, right? This is a personal story here, and then been called out by other providers. You put them on a cardiac monitor. Why'd you do that? They're DNR, and I have learned that the appropriate response here is, "Oh, I forgot." And I just take it off and, sorry about that, I'll remember next time. And just walk out, right?
Don't want to do is put the patches on them.
Do not engage. Yeah,
Don't-
but in that, don't engage. Don't try to. It's not our job to teach at that point, right?
That's not a conversation
It
you
is
have
not
at
the one
patient
you have
bedside.
bedside. It's not a real time thing. It's I forgot.
Yep.
I'm sorry, and walk away and know that you were doing the right thing for the patient.
Absolutely.
That's paramount.
Globally, right?
And if you're treating your patients as you'd want yourself to be treated or one of your loved ones to be treated, you're
Right.
rarely going to go wrong.
Yeah, absolutely. All right.
Wait. I have something borderline brilliant to say.
I love this. All right.
Oh, I lost it.
It was so close. But we're over an hour, so we cut it off. John, is there anything else of significance on here? Here, quick rattle off these numbers just so they have an understanding. And it's since 2017.
All right, so these were just Health EMS in general. We started pulling data. So 2017, we ran about 85,000 PCRs through Health EMS. In 2023, we were on scale to do 359,000 reports. So when I talk about data being important and our EPCRs being important, we've beat to death what it means for you, for legal reasons, billing reasons, patient care reasons. But from the data standpoint, UH is looking at these things and we use them. I promise you that we use them a lot. We use them almost every day. So there is a lot of importance to the documentation that we do, and having all this huge system on one platform has so much value. It's hard to quantify how much value that really is. So there you go. I love data.
Any last thoughts, guys?
You have a cat named Spot, don't you?
One announcement we do have
thank you.
is because we all think that this is a very important subject for everyone to watch and learn and understand, we're going to be creating a continuing education module about this on Fire Rescue 1 Academy. So we will, when that gets completed, it'll be worth at least 2 hours of continuing education for watching the recorded information, taking a quick online test to make sure you understand the important points, and then you'll get 2 hours of CE for watching this podcast. In addition, it is our goal that we're going to have this available for every single episode going forward. We're working through the details of that because we don't want to only do it for UH or Ohio. We want to do it nationally. So we're trying to figure out a way that we can get national CE credits for this. It's just been a bigger process than I was planning on it being. So definitely check back, and we'll announce when we have the credits available for at least UH to go on and get CEs for listening to this podcast.
Just doubling down on that. This current revision CE that we're putting in Fire Rescue 1 Academy is for UH bed controls only, and of course in Ohio only. But like he said, it's a tougher nut to crack to give everybody national CE, and I don't know that we're going to crack the international CE, not because we do have apparently viewership in Germany and South Africa and Australia, and so all of our mates out there on the other side of the pond, we appreciate you watching. And Caleb, any closing thoughts?
Documentation is essential. So thanks for being here, Data.
Thanks.
Data. So you've been sitting on that one, right? So, all right, everybody. Hey, if you like this content, please follow us on Facebook and YouTube. And as we've already shamelessly pitched earlier in the session, PreHospitalParadigm.com is the collection point for all of these episodes, all the show notes, all of Ferroni's weird outtakes and his human beatbox episodes. So all of that and more is on the PreHospitalParadigm.com. I always want to say the in front of it and confuse people. PreHospitalParadigm.com. Until next time, everybody, thanks, and we'll talk to you soon.